Welcome back to the deep dive. All right, this week, forget the gentle intro. We're jumping straight into the deep end, like a pre-op planning session.
Yeah, think of it as morning conference, but focused. We've got our critical guides here, textbook chapters, key studies.
Exactly. Our mission today tackles some of the trickiest stuff in foot and ankle, the stuff that, let's be honest, can easily go sideways if you're not careful.
That's the core of it. We're aiming for stable, plantigrade results. Doesn't matter if it's chronic deformity or acute trauma, that functional, flat-on-the-ground foot is the goal. We're cutting through the complexity.
So it's a clinical deep dive. Surgical planning, pitfalls. We'll hit forefoot reconstruction, hallux valgus, obviously, then midfoot collapse, PTTD, flat foot, and finish with acute hindfoot trauma, calcaneus, talus fractures.
And starting with the forefoot makes sense. Hallux valgus. Seems common, but oh boy, the complexity underneath.
Right. It's never just a bunion bump, as the textbooks keep reminding us.
Never. That bump is just the symptom. You, the listener, have got to train your eye to see beyond it. It's a whole first ray collapsing multiplanar failure.
Okay, let's deconstruct that collapse then. So when we're looking at hallux valgus on an x-ray, it's more than just the toe pointing sideways. There are two key angles.
Two main ones, yeah. First is the intermetatarsal angle, the IM angle. That measures how much the first metatarsal is splaying away from the second, normally. Should be 9 degrees or less.
Okay, so above 9 degrees means that first met is drifting into varus metatarsus primus varus.
Exactly. And the second angle is the hallux valgus angle itself, the HV angle.
Right.
How much the big toe deviates laterally. That should ideally be 15 degrees or less.
And when both are high, you know you've probably got a bigger structural issue. Needs more than just a distal procedure, maybe.
Right. You start thinking proximal, lapidus, proximal chevron, something to really correct that IM angle foundationally.
But you mentioned looking plantarward at the sesamoids. You said that's where the real insight is. How do they fail?
The sesamoids. They're crucial. Little pulleys for the flexors, taking direct weight. In hallux valgus, as the met head drifts medially and the toe pronates, while the tibial sesamoid gets flattened, crushed, really, by the pressure from the met head, that's abutment.
Okay, tibial side flattens. What about the fibular sesamoid?
That's the critical one. The fibular sesamoid gets pushed laterally. It slides right out from under the met head, sometimes completely into the first web space. You can see it clearly in diagrams, like figure 82.1 in the source material.
So the foundation shifts, like you said. The pulleys aren't centered anymore. What happens then, clinically?
That displacement. It's a sign the first ray isn't doing its job, weight-bearing-wise. The load gets shunted laterally to the second, third med heads mostly.
And that causes?
That's your classic transfer metatarsalgia. Painful calluses under the middle of the foot, sometimes even stress fractures in those lesser mets if it goes on long enough. It's a huge pitfall. You fix the bunion. But if you don't get those sesamoids centered back under the met head, you've just created a new, often worse, pain problem.
Which brings us to the joint surface itself. It's not just about straightening the bones, but making sure the joint surfaces line up. The whole ice cream scoop idea.
Exactly. The articular angles. This is where things get subtle but critical. Two main angles tell us if the joint itself is tilted, predisposing it to failure. We're talking figure 82.4, 82.5, 82.6 territory here.
First one is the DMMA, distal metatarsal articular angle. The textbook description is great, like a scoop of ice cream sitting tilted on the cone. Figure 82.4 nails that visual. Normal is what, 10 to 15 degrees?
Yeah, around 10 to 15 means the joint surface is pretty much perpendicular to the metatarsal shaft.
And the second angle?
That's the PAA, phalangeal articular angle. Same idea, but it's the tilt of the proximal phalanx base, usually around 7 to 10 degrees normally. If either of these is way off, the bone itself is pushing the toe sideways.
So why is correcting that DMA, that tilted ice cream scoop, so important, even if I can push the toe straight manually?
Because if you don't correct an abnormal DMMA, the correction won't last. It's a top reason for recurrence and pain. Think about it. If the joint surface itself is tilted laterally, just tightening the medial capsule is like putting a Band-Aid on it.
The bone's inherent shape will just push it back over time.
Exactly. Or it creates edge loading on the cartilage. Bad news. The source material is emphatic. Don't force the toe straight if it means the joint isn't congruent. You can't get that MTP joint to sit nicely parallel just by manipulating it. You need an osteotomy, a chevron, a scarf, something that actually rotates that articular surface back to neutral. Get rid of the shear force.
Makes sense. Okay, shifting to the OR setup. Tourniquets. Ankle or thigh? Always a debate.
It depends. Mild, moderate deformity. Ankle tourniquet is usually fine, less cumbersome. But for the big severe ones, especially if you're thinking proximal work or major releases. Thigh tourniquet, hands down.
And the reason isn't just bleeding control.
No, it's about accurate assessment intraoperatively. That's the key reason from the sources. An ankle tourniquet can cause the long tendons FHL, EHL peel to tense up or spasm.
Ah, so that tension pulls the toe artificially. Skews your view of the correction.
Precisely. You might think you've got it perfectly aligned, but it's being held there by tendon tension that won't be there post-op. Leads to undercorrection. So you accept the potential downside, maybe slightly more swelling or pain, like Conrad et al. Suggested for other fixation, because getting the bony alignment right is paramount in complex hallux valgus.
Okay, so thigh tourniquet for severe cases. We get exposure, standard inverted L capsulotomy, like in figure 82.16. Now, decision time. Soft tissue release enough, or do we cut bone? What's the threshold?
It's the 15-degree test. You reduce the joint congruently, make sure the surfaces are parallel, no tilt, then look at the toe. If the hallux is still sitting in more than 15 degrees of valgus, even after you've done your lateral release and manually corrected it as much as possible soft tissue-wise, then a distal metatarsal osteotomy is mandatory.
You can't rely on just reefing down the medial capsule?
Absolutely not. That's just asking for it to stretch out and recur. Need that stable bony platform.
All right, let's talk the flip side, the complication we all dread. Hallux varus. Overcorrection. Figure 82.88 shows it. Looks painful.
It is painful and a nightmare to fix. It's the opposite problem. Toe drifts way too far medially, historically linked to things like the McBride procedure, but can happen with others if you're not careful. The sources point to 4 main technical mistakes.
Okay, number 1, soft tissue imbalance.
Yep. You go too aggressive, laterally release the adductor tendon completely, release the lateral capsule fully, and then you over-tighten the medial capsule. You've taken away the lateral tether and yanked it hard medially.
Error number 2, bone resection.
Getting greedy with the medial eminence resection. You absolutely cannot cut into the sagittal groove.
Explain the sagittal groove. Why is that the no-fly zone?
It's that little channel in the med head where the sesamoids run, separating it from the main articular surface. If your saw blade goes past the eminence and cuts into that groove, you've basically removed the medial buttress. There's nothing stopping the phalanx from sliding off medially.
Yeah. Okay, so don't release too much laterally, don't tighten too much medially, don't cut into the sagittal groove. What's number 3?
Taking out the fibular sesamoid. That used to be done sometimes. Big mistake. That sesamoid is part of the complex with the adductor and lateral flexor head that provides a natural valgus pull. Remove it, and you lose that balancing force. The toe drifts medially.
Makes sense. And the last error ties back to the first angle we discussed.
The IM angle. Error number 4 is overcorrecting the IM angle. Bringing those metatarsals too close together down to neutral or even a negative angle, less than 5 degrees maybe. Combine that with the soft tissue mistakes, and varus is almost guaranteed. It's all about balance, restoring normal alignment, not creating the opposite deformity.
Okay, let's move proximal. From the first ray instability to a whole foot collapse, acquired adult flat foot, usually from PTTD, posterior tibial tendon dysfunction. This isn't subtle.
No, this is the arch giving way entirely. The PTT is the main dynamic support for the medial arch. When it fails, gets inflamed, degenerates, the whole structure collapses. Clinically, you see that classic triad. Heel drifts into valgus, forefoot pronates, and crucially, the midfoot abducts. That too many toes sign when viewed from behind. Figure 83.2 shows that multiplanar deformity well.
And radiographically, how do we quantify that collapse?
We look at specific angles again. Lateral views show the talus planar flexing relative to the first metatarsal. The talus first met angle increases. AP views show the talus uncovering the talonavicular coverage angle increases. That shows the midfoot abduction.
Do we need an MRI?
Often helpful, yeah. Especially if you're unsure about the stage or the tendon quality itself. MRI can show fluid around the tendon, thickening those longitudinal splits you see in degeneration, or even a full rupture. Figure 83.9 is a good example of what that looks like.
Now, surgically, the approach has evolved. The sources mention waning enthusiasm for just doing soft tissue work, like an isolated FDL transfer. Why didn't that work well on its own?
It was a learning process. The FDL transfer using the flexor digitorum longus tendon rerouted to the navicular seemed logical, boost the inversion force. But the problem was, often the underlying bony deformity was too severe, too rigid.
The transfer tendon just wasn't strong enough to pull a collapsed arch back into place.
Exactly. The deforming forces from the malaligned joints and tight lateral structures just overpowered the tendon transfer over time. It often stretched out or failed. You were putting a new rope on a broken frame.
So the paradigm shifted. Bony correction became essential. Which brings us to the calcaneal osteotomies, MDCO versus LCL, the rudder versus the keel analogy. Let's start with MDCO.
Right, the medial displacement calcaneal osteotomy. That's the workhorse. You make a cut through the calcaneal tuberosity and shift it medially, usually about 10 millimeters. Think figure 83.29. It's like adjusting the rudder on a boat.
What does that medial shift achieve biomechanically?
Two main things. One, it directly moves the heel strike medial, correcting the heel valgus.
Yeah.
Two, it shifts the pull of the Achilles tendon more medially, making the powerful gastroc-soleus complex act as a stronger inverter. It helps support the failed PTT and the FDL transfer. It's predictable, heals well, generally safer, good for mild to moderate deformity.
Okay, that's the rudder adjustment. Now, the lateral column lengthening, the LCL, that's extending the keel.
That's the big gun, yeah. For more severe, rigid flat foot, especially with significant midfoot abduction that doesn't correct passively, you're actually lengthening the outside border of the foot.
How do you do that?
Usually an opening wedge osteotomy in the anterior calcaneus, just behind the calcaneocuboid joint, or sometimes a distraction arthrodesis at the CC joint itself. You put a bone graft, often wedge-shaped, into the gap. Figure 83.33 shows the concept. It powerfully swings the forefoot back medially, correcting the abduction.
Sounds powerful. What's the catch? Why not use it all the time if it's so good at correcting abduction?
Higher risk profile. Extending the keel is structurally more demanding. LCL has a higher rate of complications. Non-union at the osteotomy or graft site is a major concern. And by definition, you're increasing the pressure of the calcaneocuboid joint.
Which can lead to
Pain, stiffness, and eventually arthritis in that joint down the line. So you reserve LCL for the cases where an MDCO alone just won't cut it. Typically the more rigid stage 3 deformities or severe stage 2. It's a trade-off.
Yeah.
More corrective power, but more potential problems.
Got it. Okay, let's pivot from structural collapse to a different kind of foot catastrophe. The neuropathic foot, especially in diabetic patients. Here, the enemy is sensation loss, right?
Absolutely. It's a completely different pathology. Yeah. Loss of protective sensation is the primary driver. Then you add motor neuropathy, causing the intrinsic muscles to fail, leading to those classic hammer toes, claw toes, see figure 86.1. These fixed deformities create bony pressure points.
And because the patient can't feel it.
Those pressure points lead to skin breakdown, ulcers. And because they don't feel the initial injury, it often gets deep infected, involves bone osteomyelitis before it's even noticed. It's a cascade towards amputation if not managed aggressively.
So Joe 1 for an existing plantar ulcer is offloading. The sources are crystal clear. One method stands head and shoulders above the rest.
Total contact casting, PCC. The data is striking. For midfoot and hindfoot ulcers, TCC heals almost 90%, 89.5% in the study cited, compared to only 65% for removable boots or special shoes.
Why such a dramatic difference? What's the magic of the TCC?
Two things. First, force redistribution. It's molded perfectly to the leg and foot, so walking pressure gets spread over a huge surface area away from the ulcer site. Second, force compliance. The patient can't take it off. It guarantees offloading 24/7. Plus, the compression helps reduce swelling.
Application technique is key, though. The sources mention a specific trick with the padding.
Yes, absolutely critical for success. Use that foam sandwich technique, contouring it carefully. Then, when you apply the web roll padding layer, you have to pull it tight, like right up to the tearing point. That maximally compresses the foam, locks in the mold. Figure 86.11 illustrates this. If it's loose, the foot moves inside, creates shear, and you can cause new pressure sores. Gotta be aggressive with the padding tension.
Okay, TCC is the gold standard. But what if an ulcer is stubborn, especially those toe tip ones? Surgical options.
For those isolated toe ulcers from fixed hammer toes, like in figure 86.9, a simple outpatient procedure works wonders. Flexor tenotomy. Just snipping the flexor tendon releases the pressure. Over 90% healing rates reported pretty quickly too.
And what about adjusting the foot globally? Tight Achilles.
Huge factor. If the patient has an equinus contracture, a tight heel cord, it forces pressure onto the forefoot during walking. You have to address it. Achilles tendon lengthening or gastrocnemius recession.
What does the data show for combining TCC with Achilles lengthening?
It's significant. Lengthening reduces peak plantar pressures by 25 to 50%. And crucially, it cuts ulcer recurrence way down. One study showed 81% recurrence with TCC alone versus only 38% if you added an Achilles lengthening. If there's tightness, not addressing it is planning for failure.
All right, final section. High energy trauma, the hindfoot smash-ups. Let's start with the calcaneus fracture. That axial load driving the talus down. Instant arthritis risk.
Yeah, these are life-changing injuries often. That primary fracture line, typically running for the tuberosity through the anterolateral wall, as shown in figure 89.1, is just the start. It shatters the back part of the subtalar joint.
Fixing these isn't just putting pieces back. There are specific goals, right?
Yeah.
6 of them.
6 critical goals you have to restore. 1, posterior facet congruency, that's the key subtalar joint surface. 2, calcaneal height, get Bowler's angle back up. 3, reduce the width, stop the heel from splaying out. 4, decompress the subfibular space, make room for the peroneal tendons. 5, realign the tuberosity, get the Achilles pulling correctly. And 6, reduce the calcaneocuboid joint if it's involved. Miss any of these and function suffers long term.
The classic approach was that big extensile lateral L incision, great view, but terrible reputation for wound problems.
Infamous, really. It gives you the best exposure, no doubt. But the soft tissue price is high. Sources quote wound complication rates needing surgery as high as 25%, deep infection up to 7%. It's operating in a traumatized, relatively avascular area.
Why is that specific area so bad for wound healing?
The apex of that L flap has a tenuous blood supply to begin with. Add the massive swelling from the high-energy injury itself, plus patient factors, smoking, diabetes, obesity, and it's just a setup for disaster. You have to respect the soft tissue envelope, maybe even stage the surgery.
So what are the alternatives? Less invasive options.
The sinus tarsi approach, or limited lateral, has become much more popular. Smaller incision, right over the fracture area. You can still get good reduction, especially with modern plating systems, and the wound complication rate plummets down to 0 to 15% range typically. Much safer envelope.
And even less invasive, percutaneous.
There's certain patterns, yes, or as an adjunct. You can use K-wires percutaneously. One technique uses a wire as a joystick, placed into the depressed posterior facet fragment. You use it under fluoro to lever that piece back up into place like figure 89.21 shows, and then pin it or screw it percutaneously. Very elegant when it works.
Okay, moving from the calcaneus to the talus, another tricky one. Mostly cartilage, dodgy blood supply. What's the biggest fear with displaced talar neck fractures? Types 2, 3, 4.
Osteonecrosis, AVN. The blood supply gets disrupted by the fracture displacement. The risk goes way up with severity, approaching 100% in some series for type Sivias with dislocation. We operate early, not necessarily to prevent the AVN, that might be inevitable, but to get perfect anatomic reduction, to give the bone the best chance, and, more importantly, prevent joint collapse and arthritis if AVN does occur.
But even if AVN doesn't happen, there's one specific malreduction that kills the outcome, right?
Varus malunion, that's the killer. The sources are explicit. Even a tiny amount of varus in that talar neck leads to a poor result almost universally. It throws off the biomechanics of the whole hindfoot and midfoot.
And how do we make sure we're not leaving it in varus intraoperatively? We need that special view.
The canale view.
Yeah.
Absolutely essential. Standard AP and lateral views just don't show the neck profile properly. For the canale view, see figure 89.41, you internally rotate the foot 15 degrees, angle the beam 75 degrees up from horizontal. That specific angle profiles the neck so you can see if it's truly straight or still angled into varus. You need that view to confirm reduction before you fix it.
And fixation strategy. What's the current thinking to prevent that varus collapse?
Dual approaches usually, anteromedial and anterolateral. While posterior screws might give great compression, the trend now is often a solid medial screw combined with a lateral mini-fragment plate. That plate acts like an anti-glide plate, really good at resisting that rotational force and preventing the head neck fragment from sinking into varus. Maintains length and alignment.
Okay, last stop. Acute ankle instability. Ligaments. Remind us, what's the impact of even a tiny bit of talar shift in the mortise?
Classic teaching point, gotta know this. Just a 1 millimeter lateral shift of the talus reduces the contact area between the tibia and talus articular surfaces by 42%. 42.
Wow, so that dramatically increases the stress on the remaining cartilage.
Hugely. Leads directly to post-traumatic arthritis down the road. Restoring that perfect mortise congruity is everything in ankle fracture and syndesmosis fixation.
Speaking of the syndesmosis, the ligaments holding the tibia and fibula together, fixation used to be all about rigid screws. What's the trend now? Screws versus suture buttons.
Suture buttons are winning the race, based on the data. Look at figure 90.15. Metal screws, usually 4.5 millimeter, give rigid fixation, but maybe too rigid. Plus, they often need removal maybe 50% of the time because they break, cause pain, or limit motion.
And the suture button.
It provides secure fixation, but it's non-rigid. Allows a little physiological micromotion of the syndesmosis, which seems beneficial. Lets patients weight bear earlier. And the big advantage, a much lower removal rate, maybe only 10%. Plus, studies suggest better functional scores, maybe because it allows the joint to settle slightly if the reduction wasn't absolutely perfect initially.
Makes sense. And finally, for the run-of-the-mill severe ankle sprain needing surgery, the lateral ligament repair.
Standard procedure there is the Brostrom, often with the Gould modification using the retinaculum. Figure 90.19 shows the idea. It's about primary anatomic repair of those torn lateral ligaments, mainly the ATFL, restore stability, prevent that chronic laxity that leads to the talar shift and arthritis cascade. #outrage.
Wow, okay. We covered a ton of ground there. From those tiny angles in hallux valgus up to major hindfoot reconstruction. Seems like the recurring theme is you need precision, but you also have to respect the biology, especially the soft tissues.
That really sums it up. We saw the DMMA danger zone in the forefoot. Ignore it, and recurrence is likely. We saw how soft tissue repair alone failed in PTTD, forcing us towards bony work like MDCO or LCL. And in trauma, it's all about getting that anatomy-perfect canale view for the talus, Bowler's angle for the calcaneus to fight off arthritis, and AVN.
Right. So technical execution is critical. Getting the angles right, using the right views, choosing the right fixation.
Absolutely. But here's the thing, and maybe the final thought for you, the learner, listening in. Even with perfect technique, complications happen, recurrence happens, especially in complex cases.
Yeah, the sources mention that specifically for things like hypermobile flat foot or severe bunions in teenagers.
Exactly. The textbook literally says, for adolescent hallux valgus, no operative procedure always prevents recurrence of the deformity. So while nailing the technical details, the canale view, the DMMA correction, the TCC application is vital. Maybe the other half of success is outside the OR. It's mitigating the risks, wound healing, nerve injury, but it's also about patient counseling.
Setting realistic expectations.
Precisely. When you know recurrence is a real risk, or that a perfect outcome might still mean some limitations, how do you communicate that? How do you define success with the patient beforehand? Because managing those expectations, ensuring the patient understands the goal, is optimal function within the realm of possibility, not necessarily a cure. That's often the difference between a satisfied patient and a difficult post-operative course, regardless of how beautiful the x-rays look. That's the art alongside the science.